This is Manos Brilakis, and this is case 119 for the Manual of Percutaneous Coronary Interventions. This case illustrates use of CTO techniques, namely the retrograde approach, for performing non-CTO PCI. The patient had previous coronary bypass graft surgery and unfortunately presented with recurrent angina and lateral ischemia on stress testing. The patient was known to have significant left main disease. There was a patent vein graft to a ramus branch. There is no competitive flow in the LAD, although a LIMA was used. And the reason is that the LIMA had become atretic. As a result, the culprit lesion was considered to be the left main, and that was successfully stented with a nice result. Unfortunately, the patient continued to have chest discomfort and came back for another coronary angiogram that shows patent stent in the left main. There is also a patent vein graft into the ramus branch. However, now it became more apparent that the patient had a lesion into the circumflex that was not previously appreciated. And that was considered to be the source of the ischemia, given the lateral location of the ischemia on the stress testing. So the plan was to perform PCI of the proximal circumflex. However, wiring of the circumflex was challenging due to angulation and because there was the previously placed left main stent. Trying to advance a guide wire was difficult because the guide wire tended to prolapse into the LAD. We eventually used the reverse guide wire technique or the hairpin wire technique, and by doing that, we were able to advance a polymer jacketed guide wire into the circumflex. This is done by forming a loop on a polymer jacket wire, usually a Sion blue or a Fielder FC, advancing the wire with the loop going forward, the knuckle going forward, and then by pulling it back, the distal bend of the wire enters into the side branch. But unfortunately, even though the wire would enter the side branch, we could not advance a microcatheter, and the reason was likely because of interaction with the previously placed left main stent. Eventually, after multiple attempts, we decided to try something different. We knew that we had access to the vessel through the bypass graft, so we decided to wire through that vein graft, which happened fairly easily by advancing a workhorse guide wire into the circumflex, and then that was exchanged for a stiff body guide wire, specifically a Grand Slam, to provide support for delivering equipment given the multiple bends. And after doing that, we were able to easily deliver equipment, balloons, and stents to the proximal circumflex lesion. So this way, we likely avoided interaction with the previously placed left main stent. Balloon angioplasty was performed into the circumflex lesion, and then a stent was delivered and placed into the proximal circumflex, providing a nice result. Once again, with the Grand Slam, we did not have any difficulty delivering the stent to the proximal circumflex. After positioning the stent, we were able to deploy it and then obtain a nice final result. The patient actually had complete symptom resolution. So several interesting points from this case. The first one is the use of the reversed guide wire technique for wiring through tortuosity. Other approaches include use of polymer jacketed wires or using angulated or dual lumen microcatheters, or sometimes using the blocking balloon technique. Sometimes equipment delivery in jailed side branches can be challenging. However, in cases like the one from our patient in which bypass grafts are already placed, those bypass grafts can be used as a retrograde route to provide access to target lesions that may not be easily accessible through the native coronary arteries. Thank you.